EPS Approach to Narrow Complex Tachycardia, continued. Q2, is atrial and ventricular tissue necessary for the tachycardia? In atrioventricular nodal reentrant tachycardia, AVNRT, neither the atria nor the ventricles are required for continuation of the tachycardia. Retrograde block, in the proximal common pathway, proximal to the reentry circuit, and anterograde block, distal to the reentry circuit, in the distal common pathway, his bundle or bundle branches, can all occur without termination of the tachycardia, or change of its intervals. Retrograde block, in the proximal common pathway, proximal to the reentry circuit, and anterograde block, distal to the reentry circuit, in the distal common pathway, his bundle or bundle branches, can all occur without termination of the tachycardia, or change of its intervals. In atrioventricular reentrant tachycardia, AVRT, reentry in AVRT requires both atrial and ventricular tissue, as evidenced by immediate termination, if anterograde or retrograde block occurs, even for a single impulse. If either anterograde or retrograde block occurs during SVT without termination, AVRT is practically ruled out. A very rare exception is AVRT utilizing bypass tracts arising in the AV node, that is, nodoventricular and nodofascicular bypass tracts. In such cases, the atrial tissue is not involved in the reentry circuit, consequently, retrograde block to the atria will not terminate the tachycardia, but anterograde block to the ventricles will. In presence of nodoventricular or nodofascicular bypass tracts, the atrial tissue is not involved in AVRT reentry circuit, consequently, retrograde block to the atria will not terminate the tachycardia, but anterograde block to the ventricles will. In atrial tachycardia, in all types of atrial tachycardia, the atrial tissue is essential for continuation of the tachycardia. The ventricles, on the other hand, are not required to maintain the arrhythmia, as demonstrated by the occurrence of atrioventricular block without affecting the tachycardia. Q3, effects of autonomic maneuvers and drugs on the tachycardia. The AV node is very sensitive to both sympathetic and parasympathetic tones. The atrial and ventricular tissue is moderately sensitive to sympathetic and minimally sensitive to parasympathetic tone. Vagal stimulation affects SVT through its effects on the AV node, increasing its refractory period, and slowing its conduction. Thus, vagal stimulation can terminate AVNRT and AVRT, but cannot terminate atrial tachycardia. It can, however, induce or increase atrioventricular block during atrial tachycardia. AV node blocking drugs, digitalis, adenosine, verapamil, diltiazem, and beta blockers, can induce the same effects on the AV node like vagal maneuvers. Class 1A antiarrhythmic drugs have little effects on AV node, but marked effects on atrial and ventricular tissue and bypass tracts. Class 1B antiarrhythmic drugs have no or minimal effects on AV node and atrial tissue, but marked effects on ventricular tissue and bypass tracts. Class 1C antiarrhythmic drugs slow conduction in all cardiac tissues. Class 3 antiarrhythmic drugs depress excitability by prolongation of action potential duration, and refractory periods, in all cardiac tissues. Approach to SVT tracings, summary. Useful observations. Surface ECG RP interval or intracardiac VA interval less than 50 millisecond, rules out AVRT. This is most probably typical AVNRT, and much less likely atrial tachycardia. Absent P waves in surface ECG indicate that it is almost certainly typical AVNRT, but it could be also AVRT or atrial tachycardia, with minute unseen P waves. So, do not take it for granted. Eccentric atrial activation during ventricular pacing mostly rules out AVNRT. This is either AVRT, or left atrial tachycardia. Rarely, it could be AVNRT with leftward extension, that is, the impulse traveling to the lower right atrium encounters resistance, and is directed via the atrial septum to the left atrium, before the right atrium. Spontaneous termination of SVT with an atrial activation wave, P wave or A wave, makes atrial tachycardia very unlikely. Theoretically, this may occur in atrial tachycardia only if accidental atrioventricular block occurs exactly at the moment of tachycardia termination. SVT with A waves more than V waves rules out AVRT, since any anterograde or retrograde block, even for a single impulse, should immediately terminate AVRT. Consequently, VA dissociation excludes AVRT. Differential diagnosis will include AVNRT, atrial tachycardia, and atrial flutter. SVT with V waves more than A waves is diagnostic of AVNRT, since this condition can only occur in AVNRT with 1 to 2 responses. Maneuvers for differentiation. His synchronous ventricular extrastimulus, and SVT entrainment by ventricular pacing, were discussed earlier. Thank you.